Good afternoon. Thank you all for making it this far. We're almost done. My name is Ellie Martin. These are my peers, Naraly, Faith, and Katja. We have been working for the past 2 years on this project, and we're proud to present it to you today. So our project was actually a systematic review on motivational interviewing, specifically on how motivational interviewing can be implemented into healthcare curricula. Perfect, okay. So, what is motivational interviewing? It's a client-centered form of counseling. It's a counseling method, and it's based on the therapist's ability to skillfully and empathetically listen to a client and be able to cause, hopefully, an internal confrontation within the client in order to induce behavior change. Now, this is relevant because in occupational therapy, we're all about the holistic approach to our clients. We're trying to understand their desires, their perspectives, and understand how we can best communicate our desires for them in our course of treatment for them. So, when considering motivational interviewing and its compatibility with occupational therapy, we have realized that the values and core principles of MI, such as partnership or evocation, closely align with our profession's emphasis on client-centered care, therapeutic use of self, and ethical process. Now, motivational interviewing is already used in nursing and dentistry, in OT and PT. Yet, it's not yet included in training programs. So, our systematic review explored whether or not MI should be a standard component of entry, and if so, which methods are best for implementation.
So I will be going over the methods that we use to conduct our systematic review. So we began by developing our search strategy, and this included our guiding research questions of what is the relationship between MI and the tenets of OT? How does MI relate to OT and healthcare curricula? And which methods are used in MI training? We then had to make these questions more focused and format them for inputting into a search database. So for example, motivational interviewing and occupational therapy. We had to choose which databases to search, which included EBSCOhost, MedEdPortal, Embase, and Web of Science. And these include a broad range of healthcare and education journals. And finally, we had to decide our inclusion-exclusion criteria. So for example, we wanted to include articles of those we found that relate to motivational interview training in OT and healthcare curricula, and that are qualitative, quantitative, or mixed method design, and we wanted to exclude articles older than 2014. Our next step was the article collection and screening. And so we collected articles by running our search in the chosen databases, which resulted in over 1,600 articles, but many of these were duplicates. So we began by importing all of them into the program's EndNote and Covidence, which help with completing a systematic review, and they flagged the duplicates for us. And then 2 group members reviewed each of the articles' title and abstract to decide if it was relevant and met our inclusion criteria. And after this step, we had 203 articles remaining. So now we read the full text of each remaining article and applied our inclusion-exclusion criteria again to determine that we would include 42 articles in our review. And our final step was analysis of those 42 articles. We performed only a qualitative analysis for this review, which included their design, sample, tools, training modalities, and findings. And additionally, we decided to use the Kirkpatrick model for training evaluation, which was developed to analyze the quality of training studies through 4 levels of measurement. So, all right, it looks like this slide got a little bit cut off, but I'll just go over. So level 1 is the lowest level in the Kirkpatrick model, and it measures participants' reaction to a training, such as with a satisfaction survey or a focus group. Level 2 measures learning through a written format, like a pre-test, post-test, multiple choice quiz. A level 3 measures learning through a more applied method, such as a simulated motivational interview. And a level 4, which sorry you can't see, measures real-world results, such as if there's a staff training on motivational interviewing, are there improved patient outcomes following that training? And so we chose to use this Kirkpatrick model because it assesses how hands-on and applied an assessment is, and motivational interviewing is a very hands-on interpersonal skill.
So as part of our analysis, we used the Kirkpatrick model to evaluate the outcomes of the educational programs. In our review, we found that 13 articles were classified as level 1, which as stated, focuses on participants' immediate reactions to the training. We also found that 21 articles were at level 2, which looked at whether participants actually gained knowledge or skills. And only 4 articles reached level 3, which measures whether those new skills were applied in practice. Notably, none of the studies reached level 4, which assesses broader results like improvements in patient outcomes. This distribution suggests the most evaluations focused on short-term impacts, with fewer studies exploring real-world applications.
Our review also examined the specific content in each of the 2 main training modalities, didactic and hands-on learning. The didactic content consisted of topics like the underlying mindset or spirit of MI, change talk versus sustained talk, which is the desire for behavior change versus the desire to maintain a current status, as well as learning to empathize with resistance to change in order to foster a more collaborative approach to change, also known as rolling with resistance. Participants also learned how to develop a behavior change plan and consolidate patient commitment. The hands-on content consisted of a mix of audio recordings with feedback, simulated patient experiences, role-play triad sessions, and other interactive role-play scenarios. These methods were found to help participants develop greater empathy, as well as improved confidence and ability to both teach and apply MI skills in clinical practice. So this graph provides a visual of the number of articles within each training format, in-person, online, and hybrid, that included didactic content and/or hands-on content. As you can see, most training programs included both didactic and hands-on content, but a few included only didactic training. Notably, a majority of the studies used an in-person format. To determine the effectiveness of the training programs, studies utilized both standardized and author-designed assessments to test both knowledge and confidence of participants in MI skills. Some established assessments include the Motivational Interviewing Competency Assessment, Knowledge and Attitudes Test, and Treatment Integrity, commonly referred to as MICA, MICAT, and MIDI. All studies found that the training was significantly effective in increasing MI knowledge and/or confidence.
All right, so as Faith just stated, MI was found to be an effective tool in various disciplines in knowledge retention and implementation. In regards to modality, we found that in-person MI versus online MI had similar outcomes, but there's an ultimate preference for dual modality due to the comprehensive approach and incorporation of students' preference and desire for hands-on learning, which makes sense, right? We also found that training durations over 40 hours received higher satisfaction ratings and suggested improved outcomes. So in other words, the longer the program, the better. And at our highest level of research, or highest quality of research, the Kirkpatrick Level 3, which included implementation of follow-up on whether or not this training program actually worked in clinical practice, participants said that they had an overall positive feedback of clinical relevance with motivational interviewing, with some challenges during implementation.
When evaluating the effectiveness of educational programs, it's crucial to consider several limitations. First, there was a wide range of assessment tools that were used, but created a lack of standardization. This makes it difficult to accurately compare different programs and draw meaningful conclusions. Additionally, most of the studies reviewed, about 50%, relied on single group pre-post test designs. While these designs can show change over time, they don't allow us to confidently determine whether the educational program itself caused that change. Finally, many of the studies had very small sample sizes, often fewer than 20 participants. This raises concerns about bias and reduces the reliability of the findings. All these factors should be taken into account when interpreting the results. Overall, MI training was found to be effective in all of the articles that span across several different health disciplines such as nursing, dentistry, pharmacy, and much more. It has been proven effective when used by occupational therapists in practice, and that is why we believe motivational interviewing to be a tool that can be taught and trained within entry-level occupational therapy programs through hands-on experience and didactic online training. For future studies, we think it would be beneficial for studies to follow up with trainees to evaluate the effects of training and to include outcomes of scoring from formal evaluations for accurate differentiation and examination of research. Additionally, we believe that future MI research should also include randomized control trials of larger sample sizes, adhering to the structured MI knowledge and confidence assessments so that quantitative analysis can be conducted to fully understand the scope of objective scores of MICA and MICAT results regarding competency and knowledge, as well as follow-up exceeding a year should also be implemented to assess training durability. Here's some references. Any questions? Okay, well, thank you so much for your attention, and a big thank you to Dr. Tribble for her guidance and support throughout our research.